afternoon, everyone. So, in maternal complications, everybody would agree that the most common complication which we encounter, though many a times we don't have a documented report telling that the patient may have an antiphospholipid antibody syndrome. That's why this topic today I have chosen. I want to take you through series of cases where you will understand like how this syndrome can present in various forms. So let's start. So she is 28-year-old lady. She is G6. Please focus on the history. That's very, very important for you to understand management. I'm going to take you through different cases so that you understand all the case scenarios, how you will encounter in your OPDs when these patients come to you, okay? So she's a gravida 6, P2L1. She has one live issue, 3 abortion, and now she has come at 13 weeks with first trimester showing increased nuchal translucency, unossified nasal bone, and reversal of A wave and DV. So when we went to her history, she is married for 7 years in non-consanguineous marriage. Her last period is 11th of November, making her EDT 18th of August. And her first abortion was at 11 weeks in 2015. It was medical termination because cardiac activity was not there. Then in second pregnancy, actually she had a early onset FGR where the flow was reversed at 26 weeks. So baby died because of that. And she had hypertension also. Then she had 2 more abortions at 8 weeks and 7 weeks. So in between, when she was going through all this because the baby died and she had 1 abortion at 15 weeks, actually she went to the doctor and she was evaluated and her APLA profile came positive in May 2018 and September. So both her lupus anticoagulant was positive at both the times and anticardiolipin antibodies was positive. It was more than 40 GPL or MPL. So she was diagnosed as a case of antiphospholipid syndrome. So what do you mean by lupus anticoagulant test and how do you do it? See, the word is antiphospholipid antibody syndrome means there are antibodies in your body which are binding to the phospholipid which is present in the cell membrane. So it can act anywhere. So this lupus anticoagulant is a test which is used to see whether the antibodies are present in your body or not. How do we do it basically? See, we look at coagulation profile where we do APTT and DRVVT test. If both are prolonged, like how you order INR, no, you order a prothrombin time, PT, APTT and INR. You will do it as a routine as you do it. When the test comes positive, you are confused why patient has a positive test, whether it is due to any coagulopathy, means any coagulative disorder, or is it due to defect, is it due to the presence of these antibody? So basically you have to rule out that why this is there, okay? So how do you confirm it? You have a test positive, coagulation profile is abnormal. You do 2 things. In one, you put patient serum. You take the ratio that is known as mixing study. You put patient serum. Serum will have lot of what? Clotting factor. If it gets corrected, it is due to deficiency of clotting factor. The patient who has this abnormality is deficient in clotting factor. They are not due to antiphospholipid antibody syndrome. But if it doesn't get corrected, you add lots of phospholipids. See the second part. When the test corrects with phospholipid, it means that it is due to antiphospholipid antibody. Do you understand this? If any query, please write. So basically, patient came to you, you are suspecting she has antiphospholipid antibody syndrome. You did the test, normal coagulation profile, which came out abnormal. Now you don't know why the coagulation profile is abnormal, due to deficiency in clotting factor or due to these antibodies. So if you add normal serum means a normal human being serum. The serum will have clotting factor. If the test get corrected with clotting factor, this means that the patient is having deficiency in the clotting factor. But if it doesn't get corrected with clotting factor, you add a lot of phospholipid and then it is corrected. This means that the patient is deficient in, patient is having antibodies which is going to bind to the phospholipid, and phospholipid when it's in excess, antibodies are neutralized, the test will come normal. This is very basic and you have to understand this. If any doubt, please ask me. I'll explain it 10 times. Okay. Now coming to next thing. So continue the history. Now She had one baby, no? So 2019, she was diagnosed. She was started on enoxaparin along with Decosprin. And in that pregnancy, she delivered a 2.6 kg baby girl at 37 weeks. Okay. Now, what is antiphospholipid antibody syndrome? It is an acquired disorder of thrombophilia. Thrombophilia means increased risk of thrombosis. So thrombophilias can be acquired or inherited. Acquired means where body starts forming antibodies against these uh, phospholipid on its own, maybe due to any other reason. But inherited thrombophilias like factor V leader mutation, antithrombin 3 mutation, you can have so many mutations. Everybody would have read about those. Methyl tetrahydrofolate reductase deficiency, so many things you can have. So we are not going to cover inherited thrombophilia. Today we are talking about acquired thrombophilia. Okay. So how does this APLA patient present? See, it can present in various forms. I told you there are antibodies which are going and causing thrombosis. So the patient can have thrombosis in the arteries, thrombosis in the vein, arterial thrombosis, MI, patient can have MI, venous thrombosis, patient can have DVT, patient can have pulmonary, CVT, cortical vein thrombosis, anywhere. Okay, this is one way of thinking. Other complications which patient can come to you in form of miscarriages, in form of FGRs, in form of fetal demises, and various group of patient you may have which will have only antibody positive and they don't have any clinical symptoms to support. In those cases, actually you're confused. So today in the talk, my whole aim is that you understand in whom you should start the treatment, even if your antibodies are not supporting or if they are not at the beyond the cutoff which we need. Okay. So how do we classify? I know everybody is very well aware with this modified SAPRO classification. So to call anybody as an antiphospholipid antibody syndrome patient, you need a clinical factor and you need a lab factor. What is clinical factor? Means that there should be thrombosis, either in artery or vein or small vessels. Or the patient may have pregnancy morbidities. What is pregnancy morbidities? That is one fetal demise at or beyond 10 weeks. Please see, this is 10 week, one only. Only one fetal demise is enough to fit in the clinical criteria if it is beyond 10 weeks. Or before 10 weeks, at least 3 losses. There should be 3, both the terms are there. Lastly, patient having one preterm birth before 34 weeks because of any complications due to placental dysfunction in form of eclampsias, preeclampsias, or FGRs, whatever it is. Along with these clinical criteria, the patient should also have lab criteria positive. What are the lab criteria? Lupus anticoagulant positive at 2 occasions 12 weeks apart, or anticardiolipin antibody positive, but what is important is the titer. It should be more than 40 GPL or MPL or more than 99. See, there are various labs are there. Some lab will report in GPL, MPL, some will report in centile. So if the value is in GPL or MPL, you call it 40. If it is in centile, see that the value should be more than 99 centile. Similar for anti-beta 2 glycoprotein. So there are 3 things: lupus anticoagulant, anticardiolipin, and anti-beta 2 glycoprotein antibody. So coming to other features. See, I told you this problem because these antibodies are going and acting against the vasculature. So they will act in the placental vasculature also. So they will cause microthrombi in the placenta. So the patients can have, the fetuses will present with FGRs, with abnormal Doppler, with oligohydramnios, low birth weight. And in NST, you may see that NST is not reassuring. So these are few points for you to pick up, because sometimes the patient will come and tell you that at 32 weeks, suddenly the water was less. Doctor told water is less, the blood flow is not good, and I had to undergo a preterm cesarean. This should click in your mind that maybe I'm dealing with a case of antiphospholipid antibody syndrome. Okay. So it can present in various forms. Thrombosis, like then we'll call it thrombotic APS. It may have only obstetric complications, so obstetric APS. Patient may have seronegative APS. Seronegative means the antibody titers are negative, but the clinical features are there, either thrombosis or either obstetric complaint. Okay. Non-criteria APS. What is non-criteria? Means, for example, I told you there should be 3 consecutive losses before 10 weeks, then only it is going to finish. So non-criteria means there are only 2 losses before 10 weeks. Then it is non-criteria. Or if I told you antibody should be more than 99, but if the antibody is just at 95, then what you will call it? Okay. Next is asymptomatic carriers. Asymptomatic carriers means, one second, just one second. Sorry. There was some network issues. So next is non-criteria APS. Non-criteria APS means, I told you, whatever is in your criteria, like there should be 3 abortions, but instead you had just 2. Or I told you before 34 weeks, there should be FGR or there should be preeclampsia, but you had it after 34 weeks. Okay. So these are few important things which you have to keep in your mind. Last is asymptomatic carriers. Means the patient only has antibodies which are positive, but no symptoms. Then what you will say? Whether the patient needs treatment or not. This is very important. So now coming to the next part of this talk. Has anybody encountered these antiphospholipid antibodies in cases of recurrent pregnancy losses? Actually, 10 to 15% of the patient with RPL can have these antiphospholipid antibody positive. But the problem is, see, the test is very costly. We know antiphospholipid APLA test is around 10,000, 12,000. Depending on your city, the cost may vary. But in average, if you do all the 3 antibodies, the test costs you around 10 to 12,000 rupees. And you have to do it twice to call the patient as APS. That is not possible. In India, people will prefer taking treatment. So many a times without doing test, and if you have a patient with 3 abortions, you would have seen in clinical practice, the medicine is given without the testing. It's not wrong. This is because the patient cannot afford the treatment, cannot afford the cost of the medicines. Okay, that is very important. So classically, APLA says there should be 3 abortions, but we all know, I hope you all have attended RPL classes. We discussed that as per HRA, even if you have 2 abortions, you should start evaluating the cases. Okay. Now, this is a very important graph table, which I have even shown you in RPL class. And if you understand this, you understand APLA very well. So the classification has modified. Now we have new classification which has come up by American College of Rheumatology or EULAR. And this is still for research purpose. We don't use it clinically. What we use is this only, modified SAPRO. So here the difference is, can you see how it has changed? Now we do it 12 weeks apart. Instead of 6, we do it 12 weeks apart. Okay. So this is nothing. I have just given you a table over here. If you want to read what's the updated thing, this is the updated thing. And we have already discussed in RPL class in a lot of detail. Now, so how much time interval should be there before you repeat? You have done the test, 12 weeks. First question I have for you all. Do you think should you do the test during the pregnancy or not? Do you think it should be done in pregnancy or not? No. Why? There are 2 reasons. I've not written the slide. You want to note it down? Kindly note it down. Point number 1. Pregnancy is a condition where our immune system is suppressed. So various and auto antibodies, if we are checking, they can come positive. They are false positive. Second, if you have any disease in pregnancy, it is the disease suppresses. If you have any autoimmune disease, be it SLE, be it rheumatoid arthritis, there will be no flare. So that is the reason there can be false positive and false negative both in pregnancy. So never do a APLA test if the patient is pregnant. Pregnant means abortion also counts in pregnancy. If patient had a recent miscarriage, please wait for 12 weeks before you do the test again. Don't do the test when she is pregnant if the patient is willing, because 12,000 rupees is not a small amount for you to waste. Okay. Now, how do you classify the risk? See, the dose of low molecular weight heparin depends on the risk of the patient. If the patient has high risk, you may need to give high dose of antibodies. You may need to give high dose of low molecular weight heparin. So any patient who has obstetric symptoms, any patient who has thrombosis, history of MI, or she has any other disease like SLE, rheumatoid, you have to give high dose. High dose is, please note down, 1 milligram per kg twice daily, low molecular weight heparin. That is not preventive dose. That is therapeutic dose of low molecular weight heparin which is needed. Okay. I think there is some network issue. Is there any lag? You all are having any lag in slide movement, or the slides are moving properly?
Yes, ma'am.
Slides are moving properly or not? I
Yes,
think there is some lag.
yes, they are moving.
It's moving. Okay, okay. I thought there is some lag going on in my system. Okay. Now, I told you clinically how you will classify high risk. I told you patient having thrombosis, patient having obstetric complications, or patient having any other disease like hypertension or SLE or rheumatoid. You will see. There is another method of picking up high risk cases where high dose is required. That is looking at antibody profile. See, if anybody has all the three antibody positive, the patient is high risk. Anybody having two positive is also high risk. So these are few things which you have to keep in mind when you are adjusting the dose of low molecular weight. Whatever said or done in these patients, if you give treatment properly, you can achieve a live birth rate of 80%. Otherwise, 10 to 30% patient only will have live birth. So your medicine is helping the patient a lot. Okay. So whenever you're doing the test, please repeat it 3 weeks apart. 3 months apart. That is 12 weeks. Point number one. Point number two, if all the three antibodies are positive, please keep the patient on higher dose of low molecular weight heparin. So how do you manage them? Start preconceptional folic acid, aspirin for them. That is before pregnancy. If you know the patient is having APLA positive, please start 75 to 100 milligram of low dose aspirin from the day you diagnose. Now, before starting aspirin, always do a baseline platelet level for the patient. And how much you start heparin? Heparin is normally in 40 milligram if the weight is between 50 kg to 90 kg. 40 milligram is given. If the weight is more than 90 kg, you give 60. The dose is 60. And how do you start? The day you get UPT positive, you start LMWH and you have to continue it till pregnancy and even in the postpartum period. Okay. Which heparin is preferred? We all know low molecular weight heparin is preferred to unfractionated because in unfractionated heparin, the problem is heparin-induced thrombocytopenia. See, there are few benefits. If you compare LMWH to UFH, unfractionated heparin, LMWH you do single dosing, you don't have to repeat injection. Second, you don't have to monitor APTT of HIT, that is heparin-induced thrombocytopenia. But unfractionated, there is high risk of HIT. You have to do twice daily dosing. But the benefit is shorter half-life. In any patient where you feel that the risk of bleeding is more, you have to start unfractionated because you can stop it, specifically in pregnancy. See, labor is very unpredictable. For example, if you have a patient on unfractionated heparin on her therapeutic dose, actually 12 to 24 hours is needed for the drug effect to go down. And if the patient has already taken LMWH, you all know, if PPH happens, we will be in a lot of trouble. So when such cases you are dealing with, in those cases, no, you can give unfractionated also for short duration because unfractionated just 4 to 6 hours is enough for you to wean off the effect of the medicine and your risk of PPH will go down. Okay. So this is very important take home message for all of you all. Now coming to dosing, we have understood unfractionated is 5,000 subcut BD. Enoxaparin, if we are talking about prophylactic dose, it is 40 for patients between 50 to 90 kg. If weight more than 90 kg, 60. And if we talk about therapeutic dose of low molecular weight heparin, that is 1 milligram per kg twice daily. Okay. Now, aspirin, we all know, 75 to 100, and warfarin also may be needed if patient, despite receiving low molecular weight heparin, is having thrombosis or complications. Now, for example, you diagnosed a patient with APLA, you started her on heparin and aspirin, but still the patient had miscarriage or patient had preeclampsias or fetal demise, whatever complication in the pregnancy. Next time, you know that either you have to increase the dose of low molecular weight heparin, or if the patient was already on high dose like 1 milligram per kg twice daily, kindly give the patient warfarin. Warfarin, we all know it is embryotoxic. We know that it can cause embryopathies, but a dose of less than 5 milligram is not that embryotoxic. To achieve, we are okay to take that risk in such cases where nothing works. No, this is the last resort, and you have to use this. the risk of complications with anomalies, if we are talking about, it will be just 7-8%. But around 93 to 92% patients can have good outcome. So we have to take that risk. But always these risks should be taken with counseling. Patient should understand what they are undergoing. And once they understand, they will know that there is good chance that we may have a live and a healthy baby. So now continuing with our case, the first case only. So I told this was all about the history we discussed, no? So she came, you read that there is NT was increased and nasal bone was anossified, all those things. So in this patient, we started on ecosprin and we started on 40 mg subcut heparin. Because of her high risk of absent nasal bone and NT and DV, we did amnio for the patient. Her QFPCR and microarray came out to be normal. Her anomaly was normal, but as expected, because she was FGR, she started because she was APLA positive. She developed FGR at around 26 weeks. But this time we were prepared. We knew that this is going to happen. So what we did, we continued monitoring for the patient. So how do you monitor such patient? See, whenever you know that there are high risk cases where the patient is prone to develop hypertensions, proteinurias, and preeclampsia, you keep them on serial monitoring. You just don't send them home like normal patient. You call them every 2 weeks. You do growth. You do Doppler for the patient, and as soon as you know that they have reached the period of viability, that around in India, period of viability is around 26 to 28 weeks, depending on the NICU. If you have DM neonatologist with you, you can even save a 26-weeker, you know that. So this patient was already at 26. Now, if we extend and we reach 28, 30, we can get a baby of 1.2, 1.5 kg. And that's a pretty good weight to be saved. So, and it's not like that in next pregnancy she'll not have. She's APLA positive. In each and every pregnancy, she's going to have these complications. So we know this is going to happen. So whatever patient is there in front of you, you try to get the best outcome for that patient, and this is the best way you can do it. So normally we stop aspirin by 36 weeks, but in these cases you have to see how the Dopplers are going. If the Dopplers are worsening and you are expecting that you're going to deliver the patient in next 1 week, you should stop aspirin. And heparin around 12 weeks before induction of labor or cesarean, you have to stop. And if there are no complications happening, we are not talking about this case. And now I'm just telling you, if no complications, by 39 weeks, you have to deliver. So what happened in this baby? Actually, from 26, we were able to take this patient to 37 weeks. And at 37 weeks, also 2.2 kg only, because this was a FGR and the weight will not skyrocket and she will be 3 kg. But at least we reached a weight of more than 2 kg. That is enough. Okay. And postpartum, we continued enoxaparin and ecosprin for the patient for 6 weeks. See, postpartum is a very important period for all these patients because whatever said or done, postpartum risk of thrombosis even more higher than antepartum. So you should continue such patients on ecosprin and enoxaparin both. When the risk is high, even the ecosprin tablet should be continued, not only enoxaparin. Okay. So you should continue in purpurium period. Okay. At 6 weeks, you can reevaluate if patient is okay, fine, everything's fine. She is mobilizing, her platelets are fine. You're not finding any risk. There is no swelling, no pain, nothing. You can stop the medication. Now coming to next case. She's G3, P1L0, no live. See, the baby died. She had a delivery at 30 weeks and the baby died, and one abortion. And now she has come at 12 weeks. And she has one report of APLA, which is positive, interconceptional period. So do you think that if the APLA was done during the pregnancy, you should take it as a positive report? No. If the APLA is done in pregnancy or within 6 weeks of delivery of abortion, you need to repeat it before taking that this patient had complications because of these antibodies. Okay? So APLA should be performed 12 weeks after delivery or a pregnancy loss. So you cannot take that into account. Now, next case, 36-year preemie. She has a history of DVT. This was not in pregnancy. 6 years back, she had DVT. That is unprovoked DVT without any reason. Suddenly she had pain in the legs and it was diagnosed as DVT. So such case becomes very high risk. If patient has thrombosis before pregnancy, So she is having vascular complications. This is very, very, very high risk. Here she will need a very high dose of low molecular weight heparin. Okay. So here 40 mg BD was started for the patient based on her weight, and EcoSprint was started. But what happened? No, at 28 weeks, basically, the patient, she by 28 weeks, we patient was okay, but the problem what was we were seeing that we didn't know when we are going to deliver this. So because we were confused on the delivery, and because of her previous history, we stopped low molecular weight and we shifted to unfractionated. As I told you, unfractionated has shorter half-life. So the duration which you need to stop the medicine before you can undergo a cesarean or a normal delivery with no decreased risk of PPH is lesser for unfractionated. Therefore, we did this switchover. Okay. So what happened in this patient? She delivered a 2.9 kg baby, which was okay. For such patient, if you achieve a 2.9 kg weight is very, very, very good. But because she has a history of DVT before pregnancy, she will need thromboprophylaxis and she will need more. So for her, basically what we do is known as switchover. What is that? Once the patient delivered, no? See, already 9 months she was on injection. We couldn't start warfarin tablets because of risk of embryopathy in the pregnancy. And now once she delivered, there's no risk of embryopathy, and we know the best medicine at this moment is to switch her on tablets. That is what you should do. Once the patient deliver, by day 2, day 3, you start her on warfarin and you continue enoxaparin also and do APTT, PT, INR monitoring. It should be between 2 to 3. Once you attain that value, you can stop LMWH and continue warfarin. This is known as switchover. You continue the heparin as you're giving. Give warfarin also and look at the INR, and once you reach the value between 2 to 3, you can stop that. Stop the injections and only continue the oral tablets of warfarin. Okay, so whenever you have, this is a case of thrombotic APS. So whenever you have a history of thrombosis, what you need is a full therapeutic dose of LMWH plus at least 6 weeks of thromboprophylaxis with warfarin. This is minimum which is needed. Okay, thrombotic APS in cases where you are suspecting any delivery urgently and you don't know when are you going to land up in problem, you can very well switch from LMWH to unfractionated heparin. There is no problem in that. Coming to next case, I'm showing you all types of cases. G4 P1L0, no live issue, 2 abortions. See, 1 abortion at 20 weeks, don't know what happened. Second, 21 weeks, APLA was done and it was normal. So now you have a patient where 3 abortions have already been, 3 pregnancy losses are there, and the APLA is normal. What do you call this patient and how do you manage it? Even if everything is negative, you have such kind of history. She is a case of seronegative APS. What is seronegative? See, we are looking only at 3 antibodies. Do you think in our whole body there are only 3 things which can have reactions? No, our tests are not that efficient. We don't look for antiphospholipid serine or prothrombin antibodies. We don't look for anti-annexin 5 antibodies. These antibodies are still not present in a routine lab test. The standards there are no standardized tests available for this. Therefore, we don't know whether these cases are actually being picked up or not. Because of this only, we start treatment in these patients even if the antibody titer is negative. So you would have seen people writing and you will think why they are writing when the antibody test is, this is over treatment. That's not over treatment. This is required because there are many things which are still undiscovered. So based on the history, you can start and there is no wrong in starting the treatment. Non-criteria, I already told you, when the criteria which is specified in the guidelines are not met, it is non-criteria. For example, 2 unexplained miscarriages before 10 weeks, or the word was 3 consecutive, no? So if they are non-consecutive miscarriage, if there is late onset preeclampsia, so it doesn't fit in the criteria, but the patient has complications. So here also, you have to start treatment. Patient can have various complications in APLA, starting from stroke, epilepsy, pulmonary embolism, hypertension, portal thrombosis, adrenal thrombosis, livedo reticularis, ulcers, scorias, DVTs, so many complications. So these antibodies can go and react anywhere. So if you have any such presentations or with obstetric morbidity, even if the antibodies are negative, I would plead to you, please start medications, because the treatment can give live birth in cases of 70 to 80% patients. Okay. So even if you look at the studies, they have found that pregnancy outcome do improve when the treatment is started. Now coming to last group of patients where antibodies are positive, but they are asymptomatic. See, only antibody positive, you have to first confirm what is the cause. See, if you have SLE, rheumatoid, Takayas, any autoimmune conditions, that can also cause false positive. Or if you were pregnant, the test was done. If you had fever when the test was done. So these tests can have lot of false positive. So you look at the history also. If it's a low risk patient, only lifestyle modification is enough. If the patient is high risk, like for example, antibody titers are positive, patient is elderly, that is more than 35 years of age, or she has chronic hypertension due to any reason, or if she has any autoimmune condition, or if she has previous history of bad obstetric outcome, she comes to high risk group, high risk carrier. So in high risk carrier, at least low dose aspirin has to be started, and if needed, low molecular weight heparin also should be added in the patient. I think this is the last case. So this is a case of secondary APLA. What is secondary APLA? Where you have some other autoimmune disease with antibodies positive for APLA. She's a 26-year known case of SLE. She has history of just one abortion. Okay, and she was diagnosed with SLE. She's on HCQ and she's in remission. Remission means the disease is okay. Disease is not causing any problem. No thrombosis, no BP, everything positive, everything negative. ANA is positive and antibodies for APLAs are positive. So what you will do in such cases? She's a low risk case. She's already on a HCQ. You only have to start ecosprin when she comes for preconceptional counseling. LMWH as if now not required until unless she has any flare, she has thrombosis, if she has history of pregnancy losses or any other complications. If you see, you can add LMWH to the patient. Okay. So for this patient, nothing. We just kept her on follow-up. Her risk of preeclampsia was high, so ecosprin dose was increased to 150. She developed hypertension at 32 weeks actually, and at 37, because of decreased movement, she was induced and she delivered normally 2.7 kg baby girl. So this is a good outcome. This is all what we want. So if we talk about management of SLE with APLA, see, aspirin should be started preconceptionally. HCQ is very important because it decreases the antibody titer. LMWH should only be started if there is history of thrombotic or obstetric APS, or maybe in the postpartum period. It's not like a routine you should give everybody. If the patient has history of thrombosis, she has history of obstetric losses, you have to give, and in postpartum period, so you have to give everybody. Okay. HCQ, how does it affect antibody? It is basically, it has immunomodulator properties. It decreases the level of antibodies. If antibody level goes down, you all understand by now that antibodies are causing the problem. If the antibody levels are going down, the complication will for sure go down. Okay. Coming to last, refractory APS. Refractory means nothing worked. You gave a therapeutic dose of enoxaparin, you gave ecosprin, HCQ, nothing worked. Now what you can do? You can add immunosuppressant in these patients. These are few patients which actually need immunosuppressant, which can be in form of IVIGs, or even certolizumab is now being given. Adalimumab is also being given. But these immunoglobulins and these drugs are very costly. Immunoglobulin for one patient for one single dose will go around 1,000 rupees, because one vial is around 60,000 rupees and it is 1 milligram per kg per day. So if you are 60 kg, you will be requiring 60 units. That will be, for that you will need two vials. So around 1 lakh rupees will be the cost of the medicine. So many patients may not afford. Increasing the dose of HCQ may help because that is decreasing the antibodies level. Increasing the dose of LMWH helps. So few complementary therapies are low dose steroids, or even in one or two patients I have seen corticosteroid also was needed and was given to the patient because of this. And lastly, you may have to do a plasmapheresis. What is plasmapheresis? Like a method where you remove all the antibodies from the body. Uh, Clinically, I have seen plasmapheresis in only 2 patients. That was of Guillain-Barré. Never in APLA patient I have seen in my clinical practice. But yes, plasmapheresis is your last option. Now coming to contraception in these patients, I hope you all very well understand that estrogen and progesterone increases your risk of thrombosis. So any patient where antibodies are positive, you cannot give COCs. That is combined hormonal contraceptive. That is why it is given WHO category. I hope everybody is very well aware of WHO criteria. WHO classify contraception into group 1, 2, 3, 4. 1 and 2 are good, 3 and 4 are bad. I'm just simplifying for you all. So anything which is 1, that is copper T is 1 for everybody. So you can give everybody. LNG IUS is 2. Dumpa, progesterone only pill, all these implants are 2. So these are things which you can prefer in these patients. Combined hormonal contraceptive is 4 in cases where antibodies are positive. It's not positive, then it is 2. Okay. So thank you very